Vikas Kohli, who has joined us today to share his knowledge and wisdom that he has gathered through his years of experience as an interventional cardiologist. Let me first introduce myself. I am Ishika Kaur. I am currently working as an art gallery manager and art writer in Panchgani, which is in Maharashtra. The EDS-IF community has greatly helped me in navigating through the symptoms I have faced and provided such valuable information to manage these symptoms and create awareness in this regard, which is really lacking, as we all have acknowledged. So I'm really grateful to the EHLERS-DANLOS Syndrome in India Foundation, that is EDS-IF, for working so hard and making sure that this community, receives valuable information from medical professionals like Dr. Vikas Kohli. We are so happy to have you here, sir. A little information about him. Dr. Vikas Kohli is an interventional cardiologist. He is the director of Delhi Child Heart Center, IP Apollo Hospitals in New Delhi. He has done his MBBS from UCMS, New Delhi, his MD in Pediatrics, postgraduate from Institute of Medical Education and Research. He has done his residency in Pediatrics from Albert Einstein College of Medicine in USA. He has done a fellowship in pediatric cardiology from University of Miami, Florida in USA. Some of his achievements include getting the Best Research Award by a fellow in Pediatrics, ACC AHA Travel Fellowship, Excellence Award in Medical Record Documentation by the Jackson Memorial Hospital, Miami, Florida, Best Research National Award, Indian Academy of Pediatrics, India, and he has more than 50 publications. He's written more than 5 chapters, and he is currently on the board of editors for 3 journals, as well as a reviewer for 5 journals. He has an experience of 30 plus years, and we're very grateful to have you here, sir. So, our agenda for today is EDS, HDS, and the matters of heart. The discussion will be around cardiac management, lifelong precautions, and advanced medical care beyond the basics. Dr. Kohli, I now leave the floor open to you for continuing your talk.
Thank you very much. I'm highly indebted to the whole community. I must confess that medical learning starts from patients, and towards the peak or beyond the peak of my career, I confess to that again that today I'm here not to teach but to learn from you all, and it's a very humbling experience to be amongst such an erudite group of emancipated support group uh, cohort who are so much aware about their illness. And I must also confess that this is not my predominant domain. So just to be able to speak up to your level, I really had to educate myself and go through significant amount of literature to prepare this talk. So I will be going through various steps in this talk. I will talk about POTS, which is basically, the symptom which predominates. My talk is mainly a medical talk. I'll try and have it in a simple conversational language for everyone to understand. Then from there, we go on to obviously heads and the POTS associated with it, and go on to dysautonomia and the cardiovascular symptoms. Most of the topics are intermingled. And then what research tools have been used via patients to actually increase our knowledge and understand the science of this particular thing. So what I'm going to start it with is, why does the symptom of fast heartbeat, that is paroxysmal orthostatic tachycardia syndrome, happen? Paroxysmal means intermittently, sometimes happening, not all the time. Orthostatic means with change of posture. Tachycardia is a fast heartbeat. So this symptom is predominant in the HEDS group of patients, but otherwise also it is existent in other patients. This has been very well studied symptom and researched also. The etiologies are all intermingled. That is, there is a neuropathic origin to it. It is a length-dependent autonomic neuropathy, which means that the longer the nerves and more distant they are from the center, which means the legs basically, that is where the neuropathy or nerve damage happens. Lower limb sympathetic. Now, the sympathetic and parasympathetic are like the yin and the yang, and they complement and balance each other, and that's how our body is able to function. And this balance is extremely fine. And what has been found is in the neuropathic part of it is that the sympathetic nerves, they do not actually supply very well the blood vessels of the lower limbs. So there is reduced constriction of the venous vessels, which are supposed to push blood back towards the heart. And therefore, there is pooling of blood in the legs. And 50% patients have this particular problem, which also manifests with less sweating and therefore can be tested with the sweat test. Now, norepinephrine spillover is decreased in lower limbs, but is normal in the rest of the body. This makes this condition extremely unique. And therefore, when the blood doesn't reach the heart, enough blood doesn't reach the heart starts pumping very fast, and thereby the symptom starts. There is also the hyperadrenergic part, which means now we are talking about an increased level of sympathetic discharge from the body, which actually increases our heart rate, which increases the palpitation, tremors, anxiety, and this has been documented by the norepinephrine levels in the plasma. This is there in 30 to 60% of the patients. 70% patients have a neuropathic component. Norepinephrine transporter gene, NET, loss has been documented in significant number of patients. The number mentioned here is the name of the gene which is missing. Hypovolemia carries a very, very significant role, and why I emphasize this is probably as of today, this is the main way we can counteract the effect. And we will go through the medical treatment and the pharmacological and non-pharmacological treatments. But hypovolemia, that is low blood volume, basically in the whole body, and it's a very complex mechanism. So this is seen not in 705 patients, but 70% of the patients. Apologies for the typo. So the blood volume or the fluid volume which is circulating in our body, is actually controlled by a renin-aldosterone system. And in spite of low renin-aldosterone levels in our body, the water retention does not happen. So the mechanism which is supposed to retain water in the body, which triggers the response to actually retain more water, is not finely developed, and which is now scientifically known as one of the causes in 70% of the patients. GI motility decreases the intake. So there is a GI element to it also. It decreases the intake due to nausea, and ability to absorb also may be affected in these patients. Obviously, we have GI specialists who could comment on this. There are other similar etiologies, autoimmune etiology and deconditioning. Deconditioning of the heart is what I'm reflecting into, and I will go to that in a bit of a moment. Now, a lot of information is from this particular manuscript, which is Potts' State of the Science Clinical Care from a 2019 NIHS Expert Consensus Statement, Part 1 and Part 2. So, incidentally, this is a sentence picked up from this consensus statement. The pathophysiology of the syndrome is incompletely understood and undoubtedly multifaceted. We as medical fraternity are confessing that we don't know everything. We need to research more. We need to find more treatments. It is not one single cause-effect relationship. And that is why a dialogue between patients and doctors can help us help other patients more, which is what I think I'm doing today with all of you. Now, POTS is predominantly, it affects adolescent or young adult women who would typically be in the midst of education or early careers. The condition can be severely debilitating, economically devastating. Misdiagnosis is so common that it takes several or few or couple of years before the final diagnosis is reached. And there is a lack of familiarity with POTS in the medical community at large, and is a misunderstood condition by doctors. The onset of POTS quite often may be initiated by a viral infection or immunological stressors or menarche, that is when the periods start, by physical trauma like a concussion of the head, or even pregnancy or even surgery. So these could trigger the onset of the symptom POTS. Acute onset, it may start just suddenly, or it may start slowly, progressively increase. Either of the two can happen. Majority report chronic symptoms. That is, once they realize, they understand they have this condition, this symptom, it continues and on. It may start suddenly, but it does not stop there. It continues. So chronic fatigue and mast cell activation syndrome may also be part of this. And GI symptoms are intricately part of all of this. Autonomic involvement, enteric nervous system involvement, immunological involvement, positive autoantibody tests which are there, and protein membrane receptors may be the reason why this may happen for the GI symptoms which dominate a lot of our patients with POTS. Now, there is a hyperadrenergic POTS also, which we just talked about. So here, peripheral sympathetic non-adrenergic denervation, venous pooling, that is pooling of blood in the legs, central hypovolemia, which means the blood volume or fluid volume circulating in the body decreases, and the patient may have a total blood volume which is lower in quantity. This has a significant impact. And we also talked about the neuropathic type, where the neurofibers may get affected. This may ultimately result in lesser blood volume. Hypovolemia may also underlie all of this, and cardiovascular deconditioning. Now, this is an important term which I want to now spend a couple of seconds talking about it. When our blood volume is less, the heart body will continue to function and the heart will also continue to function. But at some stage over a chronic period of time, heart being a muscle gets a less load, so it gets deconditioned. Let me give you a parallel that somebody goes to the gym, builds up muscles, then stops going to the gym and leads a normal life without exercising too much. So his biceps, pecs, all the major muscles will decondition and come back to a normal state or lower than normal state. This happens with the heart muscles in this unique condition of POTS where the blood volume, total blood volume is decreased. So the heart sees lesser load on it. So its muscle becomes, I won't say weaker, it is contracting like normal, but the amount of muscle mass will decrease because it is per heartbeat, it is pumping. Two things happen. Per heartbeat, it pumps less amount of blood. And second, that it is actually muscle mass decreases. So these two parameters, the heart per heartbeat, how much blood is being pumped out of the heart, and whether the heart muscle mass is decreased or not, these two parameters we can test by echocardiogram. As we all know and we have heard from the various points mentioned, that there are several factors which contribute towards this. One is connective tissue laxity, other is small fiber neuropathy. These two are the main factors which actually contribute. Also, autoantibodies inhibiting vascular receptors. Factors, we talked about low stroke volume and abnormal renin-angiotensin system. So this is an important statement from this very article, which I'm reading up, that during upright posture, there is a gravitational shift of plasma volume, that is blood volume, towards the lower part of the body, which, if unopposed by a vasoconstriction in the legs, would result in reduced cardiac preload and a fall in blood pressure. This is what is happening in our body. The autonomic baroreceptor reflex seems to prevent the hypotension and preserve cardiac output by sympathetic activation, causing an increase in heart rate. In POTS, excessive tachycardia, that is fast heartbeat, may result from a combination of appropriate autonomic responses to various physiological changes happening. Ongoing studies are examining the impact of how to increase the volume, how to increase the dietary sodium, chronic intravenous saline, albumin infusion in POTS. Now, another statement I'd like to emphasize is that yes, in decompensated patients, intravenous saline infusions are not currently recommended for routine care due to complications, but may be useful as a rescue therapy. And this should not be forgotten that ultimate pathology is low volume, so one can give higher volume and take care of it. Now, what are the treatments of postural tachycardia syndrome? There are non-pharmacological treatment. So we withdraw exacerbating symptoms, medications. Now, a lot of medications or a few medications which are used for psychiatric purposes also cause denervation in the lower limbs, and that may actually bring out POTS more. So this is the fact we need to make our doctors aware that this particular drug or some particular drugs may, and they need to check whether the particular drug they are prescribing affects this or not. So one needs to take an increased water intake, 2 to 3 liters per day. This side effect is frequent urination, which is not an easy problem to handle incidentally. Increased oral sodium intake. So we have to target 8 to 10 grams of sodium. 1 teaspoon of salt has 2.3 grams of sodium, and we'll give it to you in writing also. So one can take a buffered sodium tablets, which are available in the market. So what also helps is lower body compression garments and tight stockings in the lower body, which increase or cause a compression of about 20 to 40 millimeters of mercury. But in Indian hot climate, they may also be very tight and itchy. Now, compression garments, we'll go to this again. You can use abdominal binders also. Exercise training. Now, it is easier said than done. A person who's finding it difficult to stand, how can the person exercise? You will find several channels on YouTube which particularly talk about, and you may know about this more than me, about sitting and exercising. So there are various people who need a sitting exercise, and that sitting exercise can help those, and that's something to keep in mind. Pharmacological treatments, fludrocortisone, we will talk about this, and IV saline infusion, acute IV saline, chronic IV saline. Erythropoietin has been talked about, but this is not something I'm going to focus upon. But heart rate slowing down medicines. Beta blockers or propranolol, bisoprolol, either of these two medications can be used in medications, sometimes may worsen asthma or may cause decreased exercise tolerance, may itself cause hypotension. So this is something to keep in mind. Another group of patients may be affected by ivabradine, but pyridostigmine is a medicine which has not been found helpful when added to propranolol treatment incidentally, and its side effects include abdominal cramp. Midodrine is a medicine which has been found to be useful by some patients and definitely can be used to actually cause constriction of peripheral blood vessels. Sympathomimetic drugs can also be used like methyl dopa, clonidine, etc. I have no experience with modafinil. So these are the group of medications: non-pharmacological treatment, water intake, oral sodium intake, 3 to 10 grams of sodium per day, 2.3 grams of sodium in 1 teaspoon, and waist high compression stockings with or without abdominal compression or abdominal binder alone. Exercise training, which is recumbent aerobic exercise. They are supposed to improve the quality of life, easier said than done. Leg resistance training has been known and reported by several patients. Improving orthostatic tolerance is the aim of pharmacological treatment. That means when a person stands up, leg pooling of blood doesn't happen. How to improve this? And this is also via the autonomic, non-autonomic symptoms. One would want to improve the GI dysmotility, immune disorders, sleep problem, pain, brain fog, and headache. What has also been used is blood volume expansion, heart rate modulation, BP stabilization. We talked about beta blockers, ivabradine, midodrine, and something possibly coming through immunotherapy. And there is a trial which has just ended. And this is the IVIG treatment study for POTS, the Einstein study. The results are not yet available. Let's focus a bit more into the research of cardiovascular symptoms and dysautonomia. 89% report at least one cardiac symptom. We are referring to the subgroup of HEDS. 30% heads reported POTS. Majority, 83%, not all had an echo done. And that is 83% of these patients had echo done. I think this figure in some studies is as high as 80+%, that POTS symptoms dominates in heads group. This is a smaller study where it was 30%. 90% of the patients showed only mild valve leakage on echocardiogram. An echocardiogram, if there is an abnormality, would need to be done only once a year or once in 2 years, but intermittently can be done to assess the volume status of a patient. If symptoms have increased, we can assess, is the blood volume really gone down acutely or not? Only 8% patients had a particular type of valve leakage called mitral valve prolapse. None had aortic root dilatation. And why I mention this specifically, this is in the largest study, so to mention, is because there is a lot of confusion with Marfan syndrome because of the appearance. But in Marfan's, this is the main echocardiographic finding, which is absent in EDS. Some studies suggested routine echo is not recommended. These studies were done in countries where insurance did not allow echocardiogram to be done. In India, echocardiogram is available quite easily and at a very low cost to almost everybody, and at some stage should be done to rule out problem. Dysautonomia is the primary cause of all cardiovascular symptoms. Almost 80% had lightheadedness, 78% palpitations, 45% fainting, and 33% chest pain. POTS in general population is only in 0.2%, but in heads is almost 94, up to 94%. How do we as doctors diagnose POTS? Increase in heart rate by 30 per minute with posture change. Except in the age group of 12 to 19, it is 40 per minute. There should not be a lowering of blood pressure, which is labeled as if it's more than a 20 millimeter mercury drop in blood pressure. Usually POTS is not associated with low blood pressure. Sometimes it may be associated as an overlap syndrome. Chronic symptoms with standing are associated. They may include fainting, lightheadedness, autonomic symptoms like diarrhea, fatigue being a very dominant symptom, migraines, tremulousness, blurred vision, and these may persist for months on. Low energy, headache, cognitive impairment or brain fogging, muscle fatigue, chest pain, non-specific generalized weakness is a very dominant symptom, along with numerous gastrointestinal symptoms. So POTS is a chronic condition, but it has, incidentally, in scientific literature, no effect on mortality. This is something, some positivity towards the end of it, that we are dealing with a condition and scientific research needs to find specific treatment. We give it to the patient and the patient is better immediately and once the diagnosis is made, rather than keep on trying a various set of things which include salt, fluids, exercise, compression garments, midodrine, beta blockers, etc. 50% of patients, the symptoms start around 15 years of age, and it takes few years for it to get diagnosed. So what is specific about POTS and heads? POTS heads have a strong correlation. When a patient is diagnosed with POTS, it is recommended that heads be ruled out in the patient. 31% of POTS patients met the criteria for heads. So the reverse is also true. Other symptoms studies showed 16 and 22% of adults and adolescents of POT patients met the criteria for heads. 50% of POTS patients met the criteria for heads or hypermobility joint syndrome. So that's where the overlap syndromes happen. The major contribution of symptoms comes from dysautonomia, as we've spoken about it. Part of symptom contribution is due to delay in diagnosis. So this is something the medical community needs to work on, because if we start early with the treatments, if the diagnosis is made early, then the symptom contribution due to delay of diagnosis will not happen. So we need to see patients need to see numerous physicians. Most patients report onset between 14 to 17, and the delay impacts their social engagement, engagement with peers, and development of self-identity. These are extremely important factors for someone who is in their teen years or in their early 20s, mid-20s. So we are looking forward to accurate, timely diagnosis, and especially in population where this is likely, i.e. that is in heads. GHS plus dysautonomia 2004 was the first study. 170 adult females with age matched controls, 41% patients with joint hypermobility had one presyncopal symptom at least, while in control patients it was only 15%. Pain and fatigue were the most common symptom in the joint hypermobility syndrome group, and 22% of joint hypermobility syndrome also met orthostatic hypotension criteria. Unlike POTS, where the BP does not drop, 34% met top POTS criteria, and remainder were orthostatic intolerant. Now, this term orthostatic intolerant, you may say, okay, what is the real difference between POTS and between orthostatic hypotension and orthostatic intolerant? So if someone stands up and for a flash of a second gets dizzy, they're intolerant to change of posture. And that happens repeatedly, significantly enough that they have to grab a wall or hold on to something. 34% met POTS criteria. That means they have the symptom of fast heartbeat. That is the dominant symptom. While orthostatic hypotension, the dominant symptom is a significant fall in blood pressure, more than 20 millimeters of mercury. Now, pain, fatigue, orthostatic symptoms are common in patients with hypermobility. Whatever the reason, many patients also report dysautonomia with sleep disturbance, fatigue, anxiety. Improvement is reported with treatment. And what happens from the dysautonomia, other symptoms? This is the relationship between heads and dysautonomia. There have been screening tools, and let's talk about those. So COMPASS 31 is the main patient-reported outcome, not doctor-assessed. Patient-reported outcome, that is a composite autonomic symptom scale, which is COMPASS 31, developed by Mayo Clinic based on autonomic symptom profile, ASP. It has 31 questions to it, and I think we should be putting it up via the support group on your website or on some educational site so that patients can assess themselves. So what are the domains we are looking at? We are looking at orthostatic intolerance. We are looking at vasomotor, secretomotor, GI, bladder symptoms, and pupillometer. These are the domains of symptoms we look in COMPASS 31. This may sound a lot for the moment, but by vasomotor, we also mean blood vessel related. Secretomotor, we also mean secretions of, say, sweat. GI, everyone is familiar with. Bladder, we are referring to urinary symptoms. And pupillometer, one of the clearest indicators of sympathetic versus parasympathetic is the size of the pupil and the change in size of the pupil. So that's assessed with the pupillometer. This is one of the most commonly used worldwide tool for dysautonomia. Was used for autonomic symptoms in POTS patients compared to healthy adults, and POTS symptoms, the domains with abnormality were orthostatic were most significant, and pupillometer symptoms were also most significant. Another condition where dysautonomia happens is patients with neuropathy and those patients who had domains affected in COMPASS 31. Now, quality of life. For quality of life, 36 item short form survey is available, and we should have this available for the patients or for the support group people on their website itself. Evaluated well-being and function in POTS and dysautonomia. The survey also showed when followed up in the same patient over years, the score improved from adolescence to adulthood. Between 2 to 10 years, 51% patients improved symptoms after the POTS diagnosis was made. 19% reported complete resolution of symptoms. The level of quality of life caused by POTS alone also improves with the treatment, and quality of life for EDS and EDS plus POTS are dramatically impacted with the treatment. Apparently so. I don't see it happening. This is medical literature. And from the APS 36 data, autonomic symptom burden of EDS is fibromyalgia more than other types of EDS also. This fibromyalgia is what is also referred to as chronic fatigue syndrome, which is a diagnosis many of you might have heard that you've been labeled with earlier and then finally reached HEDS. So HEDS patient had higher fatigue, pain, and increased autonomic burden also. The median Compass 31 scores were similar in another study, detailed different. If we studied POTS versus POTS EDS, detailed differences between patients with POTS, HEDS, dysautonomia, further studies are needed to subclassify. So that's about the talk. And
Yeah. Thank you so much, sir. The talk was really, really helpful, and the slides that you've shared and the information that you've shared has cleared so many doubts. And I'm sure that the members who've joined us here feel the same. We really like the presentation and so much detail that you have given to us. With your permission, I would like to now start with a few questions that the community has shared with us and would like to be addressed. So, first of all, should people with POTS get regular follow up ECGs? If yes, how often?
so ECG, I think once at the time of diagnosis can be done, and they don't need repeat ECGs, but they also need an echocardiogram, and an echocardiogram would help us define, the first echocardiogram would help us define if they need follow-up. Where insurance regulates how many echocardiograms are done there, I think in those countries, the number of echocardiograms which would be done would be very, very few, and insurance would not allow. But in the Indian scenario, once in a year, if there is a finding, or once in 2 years also, is perfectly fine. We would want to know if the valve leakage is increasing or not. If there is a new symptom, apart from that baseline tachycardia, if there's a new symptom in a patient related to the heart, then we would want to repeat the ECG. But we also don't want to put the patients through too many routine tests, as anyways, they have so much to go through that just routine tests to reassure ourselves of the findings, we should not be putting our patients through that. So I don't think repeated echocardiograms before 1 year really help in a major way. And I don't think repeated ECGs also help in a major way. But they do provide information which actually puts them on the right track. At least something else is not being missed.
Okay, understood. Yeah. So, in the treatment plan or the management techniques, you've mentioned about compression garments. Is there a possibility that they can actually restrict the circulation and, in fact, worsen somebody's situation? And if that is a possibility, how can somebody handle it?
So compression garments are available. They have been used for several other conditions apart from POTS and in EDS also, and are routinely used for several vascular conditions of the legs like varicose veins, etc. So these compression garments definitely can help to a certain degree only. They are not a solution. What I'm thinking of is that use of compression garments can help avoid deconditioning of the heart. So deconditioning of a heart is a situation where there is muscle loss, and therefore the symptom of tachycardia will persist in spite of your doing everything. To redevelop the muscle takes a very long time. again, may take several weeks to months. So to avoid deconditioning of the heart, it is better if a person is routinely wearing, and if it is not difficult to wear it at night time, then that is something that can help. But I must also emphasize that nighttime wearing is not going to help them with daytime symptoms. The symptoms are not while they're sleeping. So occasionally during daytime when comfortable, especially with the Indian weather, and otherwise at nighttime, it may help decrease the amount of blood in the legs and thereby result in more blood coming to heart and avoid deconditioning. Now, there is no scientific basis of me saying this except a common sense knowledge. No study which has proven this, by the way.
Okay, understood. All right.
Can
So,
I make a suggestion? As you ask questions with everyone's permission, can we make it a bit conversational in case anyone has a question in between? Mr. Mukesh, can they ask the question now or should they ask later on?
No, they can ask, sir. I mean, I'll have some question, I guess.
Right.
He's raised.
definitely.
Yeah, hi. Yeah, hi, doctor.
Hi.
Actually, many things actually I could not follow because first of all, I am coming across this kind of rare condition through a genetic report, which was completely new to me. And upon reading that name, it made me pause and left me a little bit, still kind of feeling because that term itself is like it triggers a panic. But upon knowing that this is what I have been enduring for the past these years, I'm a person with a kyphoscoliotic type 2 EDS. That was what it was written in the WES, this whole exome sequencing report. So I would like to ask that just now you were highlighting about the compression garment. I didn't exactly get what it is.
Oh, it's like wearing a very long socks, but very, very tight long socks. So those are the lower limb compression garment, or it is an abdominal binder. You know, you wear something very tight around your tummy
Hmm.
so that it doesn't allow a lot of blood to stay there and returns to the heart.
Okay, then what if that the abdomen part and if wearing any tight dress is going to like make you uncomfortable, like frequent temptation to urinate, and that is what I am encountering. Actually, my gut and my pelvic organs are very sensitive, which is why I am having very limited quantity of water, for which I have been criticized and still being criticized. Even doctors are telling what some 4 to 8 glass of water you should drink, but that time I never had an idea about this condition. And when I today I completed filling the questionnaire, that time I'm coming to know the all these I was enduring, and I didn't know that this was something I had to pay attention.
Yeah, I understand your concerns. I must say that the doctors are not criticizing you. The
Hmm.
doctors don't have an answer,
Mm-hmm.
so they keep repeating the same thing.
Yeah, yeah,
And uh, and this is a field where not too many doctors know, and those who know also they don't have all the answers.
yeah.
So that is also one of the perspectives you will have to keep in mind. Yes,
Hmm.
I understand that everything that we suggest in the medical field has some side effect. That is why in the table it was mentioned that there is some side effect to everything that we do. And in
Mm-hmm.
individual patient, we have to titrate according to the comfort of the patient.
Mm-hmm. Yeah. Okay, doctor.
Yes, Ishika, next question.
Yeah, so we have a question in the chat. So I'll directly read it out. What are the disadvantages and advantages of using midodrine for POTS? My doctor is reluctant to prescribe it as I am still young, 19 years old. Can they help avoid adrenaline dumps and the psychological and not physiological anxiety? Can it help reduce fatigue and cognitive impairment?
So I wish I had the answers, and I confess that I will not have answers to a lot of questions. Um, yes, I understand the question very clearly, and I also understand why the doctor is hesitant to use midodrine in a 19-year-old. It is because they are very concerned that they don't want to give it to some young person and have a major side effect. So the doctor is uncomfortable with giving that medicine to such a young person. because they have not used it in such a young person. Maybe, I have used midodrine for several reasons in a variety of subgroup of patients, in very young children also, under 5 years also, for non this particular condition, for some other medical conditions. And I am comfortable using. So same way that doctor may not be comfortable using it in a very young person, but may be comfortable using it in older people. So doctor comfort in use of medicine is also important. And in that case, the patient has to seek opinion from a doctor whom they feel might have used it in a similar situation, or the doctor should talk to another doctor. That can also very easily, if two doctors talk to each other, the patient going from pillar to post will end. So basically induce your doctor to talk to another doctor. The doctor spends 5 minutes more, it saves your 5 hours. That's what I will suggest when a doctor says, I don't want you to get this side effect. Maybe he's not comfortable writing that medicine in a person under 20 years of age. So just keep that in mind. Okay?
Sure. So, moving on to the next question, you mentioned about pooling of blood when enough blood does not reach, which leads to pumping of the heart. And on this, what are the medical protocols to avoid the pooling of blood?
Well, the whole treatment that we talked about, the whole understanding that the distal fibers and how they innervate the blood vessels, and then when they innervate, there is loss of innervation dependent on length of the nerve fiber, that is those specifically in the lower limbs, and the norepinephrine levels in the lower limbs have been researched to be less as compared to the rest of body, which is normal. All of these, this is the neuropathic type. The second etiology group is the renin-angiotensin system, whereby the system which controls how much blood volume we should have and that fine balance it has, that system itself is not working properly, so it contributes to less volume in our body. So all these things, they add to that common symptom of pooling of blood. All the treatments we have talked about, from non-pharmacological to pharmacological up to midodrine, everything works towards the legs. That is what I have talked about today. Works towards the legs. But what I'm hopeful about is one day we will find a specific molecule which will go and work specifically on the blood nerve ending neuropathy and take care of it completely. That is how well developed scientific research is today.
Definitely. So, moving on to the next question, we talked about compression stockings, compression garments at night, but a lot of POTS patients, go through a lot of brain fog during the day. Even if they are hydrating well, they are, completing their sodium intake, but they do not see any improvement in their brain fog. What could be a better solution to managing this day fog?
So I must confess that I have reached the border of my scope of knowledge and experience. I confess that this is not something I, as a cardiologist, deal with. And I also confess that I haven't researched it enough. Maybe the group of patients who reach me have not told me to look into this, or that they are not able to solve, and I haven't promised them. But what if Mr. Mukesh gives me an opportunity to look at this and give an answer to the group of people here, and put it on the group, or pass it on to him, or to pass it on to you, so that one can get back. But I do not have an answer. I apologize for that.
No worries on that. We do understand that this is a very complex thing and research is still going on, and that not everybody has all the answers to something so severe and so, detailed. So, if Mukesh ji allows, then I think this is how we can go forward.
Yes, ma'am. Please go ahead, right?
Okay. So there is another question that we have. So the question, I will read it out. What happens if POTS is left untreated and unmanaged? Could one just grit their teeth through it?
It The answer to that is dependent on the individual, how severe the symptom is. The symptom can be so severe that it is not about, one's grit. It's about being able to do normal activities of daily living. So, majority of the people on this planet are lucky enough not to face this symptom, but some patients have very severe symptoms to the point that normal life becomes a very big challenge. A simple change of posture to standing becomes a very big challenge. So I think this is a real symptom and a real challenge, and we have to be understanding that um, I wish it were simpler and one could just tide over it, but it is not so simple, and one has to meet real patients and talk to them and feel it, and then realize that this is a very challenging situation.
Right. So, if somebody comes to you with, symptoms of dizziness, fast heart rate, or palpitations, how definite is it that the patient has POTS, or could it be linked to other things as well?
So I'll give you a basic statistic. I see about 3 to 4 patients with fainting or almost fainting per week. 10
Right.
to 15% of school going children will have a symptom of near fainting or fainting. But very few of those patients have POTS. Very few patients. And therefore, yes, this group is unique in many ways, which is why I agreed to speak to all of you on this group, because as I said in the very beginning, it is not for you, it is for my learning. I'm here. You guys are teaching me. Your questions are teaching me and making me more aware of I should, how much more I should be reading about it, and how I should be interacting with the future patients who come with this symptom. So POTS per se, that is definition of POTS is increase in heart rate by 30 by a simple change of posture, is not a very common condition in general population. As the statistics said, it is 0.2% of general population, in spite of seeing
Under-
so many patients who are having fainting.
Understood. Okay. So, we have a question in the chat. I will read that out. I recently consulted my rheumatologist for joint pain and fatigue. He prescribed Maxgilin 50 mg. However, after the second day of taking the tablet, I had increased heart rate and difficulty in breathing. My echo says I have grade 1 mitral valve regurgitation. Sorry if I'm mispronouncing it. I have
You're
discontinued the
right.
medication and I am trying to exercise. I have low BP most of the time and have other symptoms of lightheadedness too. Kindly advise.
Okay, so I'm just trying to see the brand name, and yeah, I checked that. So I think this particular symptom that you have mentioned from the medicine may be because of the medicine itself, which is a gabapentin molecule. But I'm going on to the second part of your question, that I had increased. That's fine. My echo says I have grade 1 mitral valve regurgitation, which is now obviously I don't have full medical history. I can't be treating you, but which is not uncommon in the general population also, and very common in the population that we are talking about, that is HEDS. And the person is saying, Noel is saying that he has low BP most of the time and have other symptoms of lightheadedness too. So the easiest thing for you to do is to increase your fluid intake to about 3 liters per day, increase your sodium intake to 10 grams a day, and then see how things go by. That is the easiest, simplest thing you can do without consulting several doctors. But I obviously don't know your medical condition, why you went to the rheumatologist, what the diagnosis there was. And one of the fallacies of this kind of a communication on a group, I must tell you, is that we may give suggestion, which may be totally invalid in your case, because we don't know your case, which is why this is not a medical consultation. This is a kind of a suggestion I have for everyone listening on this group.
Okay, yeah. So, moving on, why do you think people with HEDS or EDS specifically suffer through brain fog, dizziness, fatigueness? You did mention about the correlation between POTS and this, but where does this correlation come from?
I wish I knew the answer. But as I have promised, I'm going to go back and read more about brain fog and its association. And this very incisive question, I want to know who has asked this question, is a very, very incisive and very specific question. And I would like to, specifically correlate POTS with brain fog and fatigue with POTS and see why it happens. Doctor, if you have the answer, you want to let us know. I don't have the answer.
Dr. Jafri.
Okay, hi. Well, you're absolutely right. We are at the age of darkness. We don't know much, but firstly, thank you very much. It was very educational for me as well. It's very informative. Really appreciate it. Brain fog these days is very hot topic, and many people present it symptoms. But when you discuss, sometimes I feel it's either because of nutritional deficiencies and patient under influence of social media, they self-diagnose as brain fog. So if you have any of the nutritional deficiencies, iron deficiency, B12 deficiency, they can reduce your alertness, and you feel tired, you feel dizzy, and you may feel brain fog. Sometimes also it can be part of the mast cell activation syndrome. There also you can feel less alert and feeling brain fog. But as you rightly said, Dr. Kohli, it's so hard to pinpoint. It's very difficult. And sadly, most patients coming to clinic, they don't come with the exact symptoms that guides us to one of these very special conditions. They may come with bloating, they may come with diarrhea, nausea, and they don't come to my clinic as a GI clinician telling me I have POTS syndrome. Say I have nausea. We rule out everything we can. Then you say, let's ask my colleague cardiologist to say, is it POTS or is it EHLERS-DANLOS syndrome? And yet this is very difficult to pinpoint, and these patients may go to clinic, from clinic to another clinic without any answer. But I'm sure soon we will have more information and we can help the patient more effectively.
Definitely.
Sorry if I've not been of much help.
No, it's very
So
helpful. Your input is
that's
very
unclear
helpful,
for all of
doctor.
us.
Yeah.
It's very
Thank
helpful.
you so much for that point. I have a follow-up question. So not exactly a follow-up question, but a new question. So a lot of people with POTS go through the risk of, life-threatening blood vessel tears. What possible medication or treatment can be suggested to them to avoid the risk?
So I think we are referring to the vascular type of EDS here. And
Yes.
vascular type of EDS, I think there are several aspects to it. I don't specialize in this particular condition, but let me mention a few things out of the knowledge of whatever I've been reading last several days about EDS and its subtypes and the conditions associated with it. So as compared to all other types of EDS, vascular EDS is prone to very major, sudden, acute, life-threatening complications of rupture of either a blood vessel or a major organ. So that is something for which they need continuous surveillance, evaluation, and management. And they need to be in touch with a vascular surgeon, and they need to be in touch with a specific specialist related to evaluation of certain arteries. They also need to be protecting their arteries a bit more so that they do not get them traumatized and injury of the arteries, especially during surgeries or during medical procedures. For example, putting a line in the arterial line does not happen, and also surveillance with scans for dilation of the major arteries of the body needs to be done to see that those are not happening. In spite of those surveillance, there can be a rupture of an internal organ very, very, very rarely in these patients. And I don't want to scare anybody here, but this is just general information which I'm sure they have already read on various websites.
Right. So I think Lisha and Meenal have questions. I think Lisha can go first.
First, I want to thank you for this opportunity to just have a dialogue, with people. Thank you so much for that. As a caregiver to a 16-year-old, I just wanted to share this is what I do at home. Anushka has migraines with blurring vision, and she also has dizziness when she stands up or she walks. So this is what I do. We take a pinch of salt and keep it at the tip of the tongue or under the tongue. And there is always coconut water in the fridge. It really helps her. And she chugs that throughout the day. It helps more than water, maybe the flavor or something. So we have these two things, and raisins. So this is the way I'm managing it. I also had a question. So recently, my child was admitted in the hospital because she had a stomach infection and she had allergy to ciprofloxacin. And then what I noticed is that the IV that the needle, the IV that they put, the quality of the veins is different. In a day or two, it would get jammed and they would need to, have a new space. So, so is there something I need to go to a specific doctor for that? Because this is what we noticed. And thank you.
No, Lisha, you don't need to go to a specific doctor for that. There isn't. This is part of EDS, and a lot of other medical conditions that we deal with, where blood vessels are fragile, and getting an IV line can be extremely difficult, extremely difficult, or it can thrombose, or it can open up, that is, rupture very easily because the blood vessels are fragile in EDS, and which is why sometimes if long-term IV is needed, one may tend to put in a specific line which will last at least 7, 14, or even 30 days. So there are people on the group who may have gone through it or experienced it also. And but that is something, your experience is totally valid. And the gestures that you're using in terms of salt and coconut water, you're giving electrolytes through coconut water, which also has high sodium plus some fats. As was also mentioned, that certain micronutrients may be deficient. So raisins and the coconut water might be helping micronutrient and electrolytes wise. Everything you're doing is very, very valid. And it just goes to show that every single patient is so individual in what affects them and what improves them, and in the severity of the problems and the variety of problems they face. A lot of respect for all the work that you're doing.
Thank you so much. Thank you.
Yeah, I think Meenal can go ahead with her question now.
Yeah, doctor. Okay, doctor. I wanted to ask that in my case, since I am first time knowing about this condition and all, now coming across this new term called POTS. How can I find out that what all are these the terms that have been used in the session, I too must be having, a kind of moderate level or benign, something like that.
You're referring to brain fogging, right?
Actually, I was a little bit surprised that something which is concerned with brain fogging and something which is concerned with the confusion. I do have confusion a lot when someone when honestly speaking, whether it is any kind of session or whether it is any kind of adult conversation, means matured formal level of conversation. Many times I don't follow at one stretch. I need clarification, and I have the habit of constantly asking doubts to get it in a simplified version. And also, I take time to visualize it in my brain. Now, all these I can explain it, but I don't know the right kind of terminologies that is appropriate to describe it in short. So now it is coming to the pots and all. Exactly. Now I must say that I am a person now itself. Like a couple of years back, I started on BP medication because when I crossed some 30s or 29, my BP was fluctuation and it always showed high, especially during the exertion and climbing stairs. Whenever I climb the hospital stairs and all, and they check my BP, that time it is showing beyond the normal when compared to the that person of that age group and body height and weight. And it just went out of control when I was doing my examination with infection. I got infection contracted from my father, and I was giving exam also where I had no other option to compromise the studying, even if that gave it so many torture to my body, even if I was torturing myself. That time the BP that it was mandatory and unavoidable, inevitable to skip the BP medication. I tried Ayurvedic, but it was not working after that. And then currently I am on Stamlo medication, 2.5 dosage. Still it fluctuates, and I was given a relaxation medicine also along with it, like etizola and all. But I stopped taking it because it was interfering with my sleep pattern. If I stop, when I stopped taking it, I was having sleep disorders, insomnia like thing. So I stopped taking it. And all I want to know, I do get fluctuation in the heartbeat and like that and all when slight stress or when something emotional on the emotional front, some a shock I encounter. Then I do experience all these palpitation kind of thing, increased heart rate. So exactly, I'm not getting how to make sure or how to find out that even I'm also having all these kinds of, the traces of POTS or whatever have been discussed in the session.
So, Meenal, I must say that you are a very inquisitive person, which is why, you ask questions, and almost all of us don't understand everything at the first go also, especially, things which like this, which are very complex and presented in a rather complex way. In spite of everything, this is still a very complex presentation and a complex topic. Now, going back to brain fog. So we know that the blood gets pooled in the legs, being in pots, and we know that because of that, there are certain hormonal responses in the body. The same thing is happening in our brain, that the blood supply reaching the brain when we are standing, the brain is farthest from the leg in gravity terms, so is most affected by gravity. So the blood to the brain becomes less. And so what the brain does is it tries to compensate that the blood supply is not less. And in that process, it secretes its own hormones, and that makes our brain go fast, which causes a bit of a confusion because it's trying to do too many things too fast simultaneously because of hormonal response. So this is what is brain fogging essentially. As Dr. Jaffer mentioned that the term is used in exchange for several things, but basically there are several things which contribute to it. One of the most common things I come across which contributes or triggers brain fogging is lack of sleep. So if there is any suggestion I can make to anybody to improve brain fogging, whatever little one can do is please sleep well, try and sleep well. Understanding very well that sleep itself or getting enough sleep itself is one of the problems in this condition itself. So, yes, it is a very complex problem. A lot of us are trying to help each other over it. And each one of us are giving our individual experiences. All that is very nice. And if we continue to do this, we will all go a step ahead and help everyone to feel better and get better also.
Thank you so much for that answer, sir. I think I'm done with the questions. If anybody has any other questions, please go ahead. Otherwise, we can conclude the talk. Okay, seeing that there are no... Yes.
I need to thank, yeah, Meenal.
Sir, one more thing. I had a doubt that till now I was thinking that whole exome sequencing was the major part of the genetic testing. Now, as per my situation, do you think that I should go ahead with any other kind of, little bit advanced level of testing, that is WCG, that term I saw?
I think you need to speak to a geneticist. I'm not a specialist in which type of testing will help you most, but a geneticist would be able to help you out in terms of planning, because these tests are also extremely expensive.
Yeah.
WES, can cost upwards of 20,000 plus. So just be aware of what the outcome is going to be. Ask them before you undergo this test. I tell all my patients, please ask the doctor who's advised this test, what is the benefit going to be if I come to know, apart from
Right.
just knowledge. So ask a geneticist about it, and I think that will help.
Okay, sir. In Kerala, I got it done for 11,500.
Yes, there are companies who are doing it as a group for that cost. You are right. So I wanted to actually thank everybody who's here, and I think you did a great job as a compare for the whole group, and you've been excellent, Ishika, and Mr. Mukesh, who's been instrumental and making sure doctors learn. It may seem that this is a session where I'm giving information, but to tell you the truth, I'm the one who's learning. And I think I will initiate and trigger the process where a lot of people associated with me in any form or way get to learn about this condition, its insight and its details. And also, I really appreciate that this talk is going to be put on YouTube, where anybody and everybody who can type the keywords will get access to all the information that we've discussed here today. Thanks a lot, and God bless each one of you.
Yeah, definitely. Thank you so much, sir. Before we conclude, I think we have a few more questions from him. I think you can go ahead.
Is it
Yeah.
me?
Am I
Oh, sorry.
audible?
Yes, you're audible.
Oh, yeah. Hello. Hi. Thank you for coming here and talking to us about it. I'm kind of young, and I have like a bunch of things going on. I've got like autism, ADHD. I've got the hypermobile EDS, and then like I've got migraines, and like I don't know. I feel like that's not just what I have. I really feel like there's more stuff going on. How do I like go about managing all of these things with like being a college kid? It's just none of this is making sense to me.
I understand where you're coming from, and I understand that it seems very overwhelming. But the very fact that you mention all the conditions that you've mentioned, and the fact that you are in college, I think you are, or your family, or whosoever is taking care of you, is doing a great job, and I congratulate them. And the very fact that you sat through this discussion and heard it all, I think is also very encouraging, that you're keen to know more. And I think it is the cohort of doctors whom you're associated with in the geographical location that you are, who are going to be your best friends to guide you and take you through your challenges. As I mentioned earlier, that each individual patient can have a variety of combination of things, exactly like you have. And it is very difficult to make any comment which might appear wrong also at times because we don't have full information. So I suggest that sitting with your doctors and discussing your worries, anxieties, and also medical solutions is the best way to go ahead. And I emphasize that the very fact that you're in college and you seem overwhelmed is a way that you will find a solution to your challenges.
Okay, thank you so much.
Sure. All the
Thank you.
best.
I think Lisha, you can
Uh,
go ahead with your
yeah,
question.
yeah. So, yes, sir. So I just need to know, uh, what kind of doctors do we need on a panel for an EDS, HEDS patient to consult? So we know cardiologist, we know rheumatologist, ortho surgeon. Can you just give us a list? Can you just tell us? And I wish they were all connected to each other. Can we create a panel of doctors? And then we, as a EDS patient, we just give our reports to one place, and there is this cooperation and coordination among doctors to help us. Most of us are confused, where should I go next? So what are the kind of doctors or specialists we need on a panel? Can you please tell us? And then once the registration is done, I will be attacking all multi-speciality hospitals and trying to get this done. But sir, is it possible that you can get it done and tell us the list, sir? Thank you.
Right. So I believe a lot of us are in different cities, and a lot of medical discussions, as much as they happen, via teleconsult, one may feel better, or the doctor may feel better by individually meeting the patient. So to give a totalitarian answer to the challenge of the list of doctors and each one of them I can meet and consult or discuss with may seem to be appropriate, but rather difficult in especially patients who are complex. So I think what I will do on your suggestion, Alicia, is prepare a slide which has the name of all the specialties. I will pass it on to Mr. Mukesh, and I will also look into brain fog and pass that information on, two homeworks that I'm taking with me. And it'll be available to all of you. I will pass on this information to them, and it'll be available to all of you through them. This is my assurance to you all.
Thank you, sir. Just add psychologists and psychiatrists too, sir. We need all of that.
Definitely. Yeah, I need them too.
Thank you, sir. Thank you.
Absolutely, we all do.
Neil, please go ahead.
Doctor, I just wanted to get it confirmed whether a person with this kind of condition, are they vulnerable to or prone to developing some kind of behavioral issues, like impulsive nature, or kind of problem in tackling or taming their emotions, and different kind of thinking, or different kind of the way of executing, or talking, mingling, like that kind of, are they this kind of, is it traits are visible in them?
So I will confess, I specialize in the heart and matters of the heart, but I will give a very brief answer to your question that all of us are prone to all kinds of situations, challenges, and behaviors. All of us, everybody. There is nothing called a normal behavior. Okay. And everything is acceptable. We behave based on our experiences in life. We all individually have been through different experiences. So everything is acceptable, and it needs to be dealt with in an appropriate way by the appropriate specialist. And that's all that needs to be done. And I think no one diagnosis is more prone than the other. It is our individual response to what we face in our life and a combination. Plus, yes, as was mentioned, there are certain conditions where genetically one would get more so, but those are major psychiatric issues rather than just behavioral issues, just to highlight.
Okay, I was also detected to be having a variation in a MAS3 gene. So that is why I doubted, because the thing is, I know that my behavior is a little bit odd, and I have anxiety issues. I am impatient while talking to people, and often I have faced the kind of irritation from their end. So it's something I am trying to get over it, and I am trying to heal myself, but it's taking time, and it's like something I am constantly coming to the square one.
So I confess again and emphasize again, I deal with matters of the heart, and I can help best. You can use my suggestions for that, but for other things, I also need a doctor.
Yeah. As Lisha ma'am said, that we also need someone who is dealing with the psychiatry and therapists.
Yes.
Yeah, in the group, and also
True.
for the skin disorders, because I'm having rough patchy skin due to the pressure I am applying for my body stability. That I cannot help, I cannot avoid. Otherwise, I will, my body, but my body is habituated to lean somewhere, or take the support of some external surface, or maybe probably a part of my body, especially my elbow. So that is what creating this rough patches on my skin, the scars, and is taking time or nearly impossible to heal, despite going to dermatologist and taking cosmetic creams. It's of no use.
Right. I fully understand what you're saying, and I empathize with their situation. And I'm hopeful you will find the right doctor who will help you with that.
Yeah, okay, sure.
Yeah. Yes. Thank you so much, Meenal.
Right,
I'm sure
Ishika,
we
and
have.
thanks everybody on the group.
Thank you everyone for giving me this, for adding me to this group to come across this beautiful session, and also helping me in self-discovery and more ahead.
Yeah. Thank you so
Thank you.
much. Thank you so
Thank you,
much
sir.
for joining.
Thank you, Dr.
Sure.
Kohli. Thank you.
Thank you so
It's been a
much.
pleasure. Right. Take care,
God
all of
bless
you.
you all.
Bye-bye.
Thank you. Bye-bye.